So for those who haven't met me before, my name's James Betteridge-Sorby, and I'm a GP partner at Swadlincote Surgery, right at the bottom of the county. I've had a chat with sort of Shella and Susie over the last sort of 12 months or so, and there was a desire to use some of these sessions to look at the LGBT plus community and their health needs, but also think about perhaps how in primary care we respond to LGBT plus staff members that might be working in our premises. So I'll run through today a little introduction to myself and how I got involved in this work. I'll outline what I plan to cover in today's session, but also the two other sessions that are planned for this strand, which, if my memory serves me correctly, are the last Thursday in May next month and the last Thursday in August, so a little break after that. Shelley was quite keen that I include a section particularly on some of the terminology that is often used around LGBT plus health, and I'm setting that in the context of the history of sort of LGBT plus rights in this UK, because I think it's really important to understand quite how the legal framework for how LGBT plus people are viewed in this country has perhaps sort of shaped some of the health needs. Talk a little bit about sort of the LGBT plus population in the UK and how perhaps some of their health and health related behaviours differ from that of the rest of the population. A little bit about health inequalities, and end with a little bit of a sort of case discussion, which will hopefully act as a primer for the next session in May. So just a little bit about myself. I've been a GP now for 10 years, and towards the end of 2019, myself and some other colleagues from the RCGP who identify as being part of the LGBT plus community, and by that we're talking about those that identify as being lesbian, gay, bisexual, transgender, or, as we'll go on to discuss, the plus part of that. And we came together really to have a think about whether there were perhaps insights that we could offer as clinicians, not only to improve the environment for other LGBT plus members of staff working in primary care, but use our own insights to perhaps improve services for patients that come from those communities. Because I always think one of the unique things about general practice is that every GP has a GP. Every GP, you know, kind of will go and see their GP about something. So we are in that sort of position whereby we are all patients as well as providers. I got married in 2016 to my husband, Stephen, and both through my own sort of health problems and my husband's health problems as well, I've also been able to gain quite a few insights as to what it's like to be either the spouse of an LGBT plus patient in the NHS or even be on the receiving end of care myself. And as one of the things from the RCGP used when we had a Pride Month thing, as it says on there, as a patient, I've experienced the awkwardness of having to explain who my husband is. You know, kind of for a heterosexual couple going into a consultation, if the man's a patient, there's a woman of roughly the same age that goes in there, it's generally taken as read that that's their wife or life partner. Whenever my husband comes with me, that's generally kind of results in a question about that. Who is this person? Why are they with you? As a GP, it gets even more confusing because often other people, for fear of wanting to offend me, tend to kind of refer to my husband as my partner, whereas from my point of view as a GP partner, my partner are the people I do business with, my husband is my husband, and I you know, kind of retain that word as much as anybody in a heterosexual marriage would do. The other reason I leave this slide up on is if you Google RCGP LGBT plus health, you'll find all sorts of resources on there, including some podcasts that I've contributed to alongside other members of staff at the RCGP, and they're well worth sort of looking into. And my understanding is that you can get that sort of freely available regardless of whether you're an whether you're an RCGP member or not. So today's session is an introduction looking at sort of the overview of the population terminology and some of the background health inequalities. The second session at the end of May, that's going to look more at the clinical care of LGBT plus individuals. And in that, I'm going to be particularly focusing on things like screening, especially around cancer screening, health promotion, gender dysphoria, which I know there is a lot politically kind of in the air going on at the moment, and things like the Tavistock case and how easy it is to refer in has all sort of changed within the last 6 months or so. So hopefully I'll be able to bring people up to date in what is quite a sort of moving field at present. A little bit about fertility support, and also a little bit on post-exposure prophylaxis, pre-exposure prophylaxis and HIV. I'm always very keen that sort of anything around LGBT plus medicine doesn't always boil down purely to kind of sex and HIV, but it is kind of an area that I often find GPs aren't perhaps as sort of knowledgeable in and skilled as perhaps they might be. So I will cover that in the next session. And as I say, session 3 is looking more at the support we can do sort of within our own sort of practices and for our own staff members. So I'll talk a bit about sort of visibility within the organisations, what any coding considerations, what sort of accreditation schemes there are, and further learning for practices, and a few kind of HR considerations around kind of contracts and partnership agreements and some of the wellbeing support that's available for LGBT plus staff. So as I say, kind of that's the sort of overview of kind of where I'll be taking these sessions over the next few months. So if we begin by thinking a little bit about the history side of things, we've only got to go back relatively recently to 1967 to remember that was the point at which sex between two men and in private was decriminalised. So kind of at that point, prior to 1967, sex between two men was an illegal act. The person that's over my left shoulder, if you can still see me on your screens, is Alan Turing, very much an idol of mine. Those of you that are aware of his code-breaking work during the Second World War will know that he was chemically castrated as a result of being convicted for having sex with another man. And when it was decriminalised in 1967, it was only decriminalised if it was to take place in private, without anybody else being aware of it. You've probably heard of the organisation Stonewall that does a lot of advocacy work around LGBT plus people. The Stonewall riots occurred in the USA in the late 1960s, and that's really what kind of triggered the modern Pride movement around the world. 1972 is when the first Pride event was held in London, and that attracted around 2,000 participants at that time. And when you think how big kind of Pride, kind of is these days, kind of you see that sort of shift in how attitudes and the landscape has changed in the last 50 years. And I purely put this in for context only. 1984 was when I was born. So in 1992, or in other words, when I was when I was 8, that's when the World Health Authority declassified same-sex attraction as a mental illness. So up until the age of 8, the person that I am now was technically classed as being mentally ill for being attracted to somebody of the same sex. And it was only in 2002, so around about the time that I was sort of turning 18, that the UK government lifted the ban on lesbian, gay and bisexual people serving in the armed forces. It was at that time as well that the age of consent was lowered to 16, the same as that for heterosexual relationships, and equal rights were granted to same-sex couples wishing to adopt. A couple of years later, in 2004, is when the Civil Partnership Act came in. So that was the act that enabled a legally recognised union between same-sex couples, largely to kind of enjoy some of the economic protections that marriage had previously already given to heterosexual couples. And in 2008, that was when the Human Fertilisation Embryology Act recognised same-sex couples as legitimate parents of children conceived through donors. So in other words, if you were a lesbian couple having a child via a sperm donor, it's at that point in time that you begin to see two women listed on the birth certificate as the parents of that child. So a lot of relatively recent sort of changes. 2010, we have the Equality Act published. That explicitly includes gender reassignment as a protected characteristic, so something on which you cannot discriminate if a patient has had their gender reassigned. And 2014, that's the point at which the Marriages Same-Sex Couples Act came into effect. And under those grounds, marriage is seen as being equal to that of a heterosexual marriage. So in my case, as somebody that's married, not civil partnered, that only came into being 2 years before I got married myself. Interestingly, in the current, kind of political climate, where I think people will recognise there's a lot of noise around sort of gender issues, transgender issues. It was only in 2019 MPs voted in favour of LGBT plus inclusive relationship and sex education for all schools in England. Obviously, education is a devolved matter to some of the other nations. And I think it's perhaps worth just sort of reflecting on that, because obviously, again, there's a lot in the press currently about where LGBT plus education might be heading, and whether there's a mood in government and some sections of society that feel that the advances that have been made over the last 50 years or so are potentially, for some people, being a step too far, but for other sections of society, still nowhere near enough. And as I've already hinted at, when we think about LGBT plus community, the terminology is important, but also potentially contentious. And that's why I've kind of got the minefield warning sign here, because I think it is an area where people do struggle. I think some people struggle because they don't want to offend inadvertently. I think there are other people who, kind of won't necessarily embrace one person's definition of a particular word in the same way as somebody else would. So I've been quite purposefully clear for this talk in that I'm using the definitions that are defined by the Office of National Statistics. I realise that these aren't definitions that are universally accepted by everybody. And in that, I'm including people that don't accept them from the LGBT plus community and those that are outside of the LGBT plus community. But at least by using their definitions, that's often what a lot of the data is derived from, that goes on to inform the health inequality stuff that I'll be moving on to. So in simple terms, the way I like to think about it is, if we talk about sex, your biological sex, I think of that as being the anatomy you go to bed with, kind of your anatomy, your chromosomes. Your gender identity is who you go to bed as. So I go to bed as a man. And the sexual identity is who else you'd like to go to bed with. So in other words, kind of as me, as who's a gay man, attracted to men, that's my sexual identity. So in my case, I go to bed with the anatomy and chromosomes of XY. My gender identity is I go to bed as a man. My sexual identity is I go to a man who's attracted to other men. So, as I've already said, when we think about sort of sex, the biological aspects of an individual is as determined by their anatomy, which is produced by their chromosomes and hormones. Generally, we would class that as being male or female, and that's something that's assigned at birth, usually. But it's always worth bearing in mind that even before we go on to look at sort of transgender issues and issues around gender identity, we know, and you'll remember kind of from your embryology and things back at medical school, that there are naturally occurring instances of variation, or what we might call intersex, or sometimes that gets abbreviated to DSD, disorders of sexual development. And some of you will be aware around the issues in the press, particularly kind of around sort of athletes and transgender people wishing to take part in sports that are historically segregated by gender. And one of those is an African athlete called Caster Semenya. She was born intersex with XY chromosomes, but ambiguous genitalia, so was assigned a female gender at birth, raised as a female, and she's now banned from competing in certain events unless she artificially suppresses her natural testosterone level below that of 5 nanomoles per litre. And that just sort of goes, I suppose, to kind of suggest kind of how this is a bit of a blurred area, given that historically, probably people with some form of selective advantage as a result of their intersex status may well have gone on to achieve other things. For those of you that are more kind of into trashy celebritydom like myself, anybody that watched I'm a Celebrity a few seasons ago may have come across a lady called Lady Colin Campbell. She's a socialite, author and royal commentator. She had a genital malformation at birth, fused labia and deformed clitoris, even though she had an XX karyotype. And at that time, the medical advice she was given in the 1950s or so was to assign her as a male so that she could live what was deemed a normal life, as what was thought of at the time as a superior sex. And she didn't have the corrective surgery needed for her issues until she was 21. And then she began modeling as a female. And she's written of the personal issues she faced being raised as a boy when she was biologically female. So as I say, kind of it is a complex area, and one whereby nature in itself presents some of this complexity. So if we think about sexuality and the terms around that, lesbian, a woman who has significant attraction primarily to members of the same-sex gender. Gay, one who has significant sexual attraction to members of the same sex or gender. Gay, whilst it will cover men and women, typically tends to refer more to men, the term gay. And with bisexual, that's the potential to be sexually attracted to people of more than one gender, but not necessarily at the same time, in the same way, or to the same degree. So there may well be people who identify as being bisexual, but will exclusively have relationships with people of one gender throughout their whole life. There may well be other people who have, periods of time whereby they're in relationships with men, periods of time when they're having relationships with women. Other terms that you might increasingly hear referred to is that of pansexual, which is defined as being sexual, romantic, or emotional attraction towards people regardless of their biological sex or gender identity. And some people refer to that as being gender blind. And what they basically mean by that is that when picking a romantic partner, gender and sex are not the determining factors in their attraction to others. Another way that I've kind of heard this expressed is these are people who fall in love with souls, not bodies. So, kind of that's one way of perhaps thinking about it. And another term that you may come across is asexual. So these are people who do not experience sexual attraction towards individuals of any gender. That's not to be confused with celibacy, which is a personal choice to refrain from engaging in sexual behaviors. So, somebody who, say, faith reasons, like a Catholic priest who's taken a vow of celibacy, that's a personal choice to do that rather than being asexual. If we move on now to think about gender identity, the Office of National Statistics defines gender as a social construction relating to behaviours and attributes based on labels of masculinity and femininity. Gender identity is a personal, internal perception of oneself, and so the gender someone identifies with may not match the sex, and in this case, the biological sex, they were assigned with at birth, and that's the current Office of National Statistics definition. So if we think then about how we then split that up, a transgender person is a term for those whose gender identity is not congruent with the sex they were assigned at birth. So a transgender woman may have been born with male genitalia, male XY chromosomes, but they identify as a female based on those social constructs we've just mentioned. One term you might come across is that of cisgender, and essentially that's the polar opposite to transgender. So those whose gender expression and gender identity are congruent with the sex they were assigned at birth. So I could say that I am a cisgender man. Increasingly, you might come across terms such as non-binary, and that's generally used as an umbrella term for various non-conforming identities, and are mostly used by those who do not strictly identify their gender as being within male or female. So perhaps a good example of that, I believe, is the pop artist Sam Smith, I think, has identified as non-binary. And gender fluid is a term that you might come across, particularly kind of younger people sometimes use this, and that applies to a person whose gender identity changes over time. So it may well be that they identify in one gender at one point in their life and then move over to another, or spend periods of time identifying in one way before others. Just to finish off sort of the terminology section, other terms you might come across in this sort of area is the word queer. Certainly when I was sort of younger and in the school playgrounds, queer was often a quite derogatory slang term. And that, for that reason, it's a term that sort of doesn't always sit comfortably with people in the LGBT plus community. There are some who really embrace that term and actually kind of feel that sort of queer should be a kind of a reclaimed word used by the community to describe those who reject sort of the normal sort of traditional heteronormative sexual male-female type view of the world. As I say, there are others who, you know, kind of based on its derogatory use in the past, actually still find it quite an offensive term. And it's for that reason that I personally like to use the LGBT plus acronym rather than the LGBTQ plus acronym. Both are, you know, completely valid. But for me, I just think by having the plus but not having the Q in all of my shorthand, it helps to protect those people who perhaps find that queer is still a damaging word for them. Allies are people that align with and support a cause. So you'll often hear the term straight ally. So that's an individual outside of the LGBT plus community, but who is very supportive of their fight for equality and rights. And again, you might have come across this issue of pronouns. Our pronouns that we use in speech are usually sort of gender based. So, you know, James is a doctor, he works at Swaddling-Coat Surgery. Some individuals may feel their gender identity is better represented by alternative or neutral pronouns. So some non-binary people might prefer to use pronouns such as they stroke them, so gender neutral ones, rather than the gendered ones of he and him, she and her, that kind of thing. And increasingly you might see people put their pronouns in sort of email signatures or in talks, and I think that does one of two things really. One, it kind of demonstrates kind of how you'd like to be addressed, but more importantly, it shows that because I'm saying that this is how I'd like to be addressed, I'm open to you telling me how you would like to be addressed as well. And it's one of those sorts of things whereby it can be a shorthand for sort of saying, I'm somebody that understands that this might be helpful for you to inform you of how you like to be addressed. So if we move on from the terminology side of things, just to have a think about the LGBT plus population in the UK. In 2019, the Health Survey for England that sort of looked at people over the previous 7 years estimated that about 1.4 million people in the UK aged over 16 identified as lesbian, gay or bisexual. So that's about 2.7% of the population. It's a lot harder to do studies on the trans and non-binary community, largely because the data sets are a little less reliable. But it's thought that that community is likely to make up around 0.2 to 1% of our population. And I think it's fair to say that the size of the LGBT plus population has grown over recent decades, essentially as laws and societal norms have changed. I think particularly in relation to sexuality, that's not to say that, you know, kind of those sexual behaviors didn't occur, you know, prior to that time. Of course they did, but that was often within the confines of more conventional kind of heterosexual marriages, even if there were men or women that were having other sexual encounters with same-sex partners outside of that sort of societal norm. So certainly kind of acknowledging that there will be, you know, geographical sort of variations, and I suppose we kind of think of places like, you know, London, Manchester, Brighton as being kind of particular sort of hotspots for the LGBT plus community. If we assume about 3% of the UK population identify as LGBT plus, that would equate to around 450 patients in a large practice with a list of about 15,000 patients or so. And I think it's worth just sort of pausing just to kind of think whether that feels right, whether that kind of feels a hell of a lot, whether it doesn't feel enough for your own sort of practices, really. Certainly, you know, kind of for my practice, and we've got a list size of about 14,000 in Swadlincote, that certainly seems a lot based on what I see day to day, but obviously kind of unlike ethnicity, whereby it's, you know, kind of a little sort of easier to kind of tell the difference between somebody who's coming into a consultation from an Asian heritage as opposed to a white Caucasian heritage. Obviously kind of sexuality doesn't always present itself as part of a consultation, so kind of you wouldn't necessarily know who you are dealing with, and we might touch on as to whether that's a good thing or not. So in 2018, the government's Equality Office launched its first national LGBT survey. And as I say, the results were published in July 2018. And there was over 108,000 people who responded. So at that time, it made it the largest national survey of LGBT people in the world to date. Again, kind of obviously kind of the ability for people to be open about their sexuality varies from country to country based on how progressive the laws are there, which obviously then limits kind of how easy it is to obtain data in other countries to compare sort of like with like. I won't sort of read all of this, but interestingly, the forward to the report was written for the Minister for Women and Equalities at the time, who was Penny Mordaunt, who some of you might remember was the runner-up in the recent prime ministerial leadership race when Rishi Sunak became Prime Minister. And at that time, it was noted that LGBT people are less satisfied with their life than the general UK population, especially with trans respondents having particularly low scores. More than 2/3 of LGBT respondents said they avoid holding hands with a same-sex partner in public for fear of a negative reaction from others. And I myself, you know, have been, you know, the victim of, you know, kind of pejorative comments when I've been out and about with my husband, even if we've just been walking together, not holding hands, but just together, you know, kind of name calling still exists, as in the same way that I suppose for people who come from non-white racial backgrounds still experience racist slurs in the community. And as it goes on to say in here, 2 in 5 respondents experienced an incident because they were LGBT, such as verbal harassment or physical violence. 2% of respondents had undergone conversion therapy with people attempting to cure them of being LGBT plus, and certainly in LGBT people that come from strong religious family backgrounds, that still can be a significant issue. A quarter had accessed mental health services in the 12 months prior to the survey. And as it says on here, none of this is acceptable. There's a lot more to do. And part of that comes from education, hence the reason why we're here today. In July of 2021, NHS Digital published health and health-related behaviours of lesbian, gay and bisexual adults. It didn't include trans people, largely because the main health survey didn't include an initial question about gender identity. So therefore, it was harder to marry up the other physical and mental health behaviours with people that came from that community. But it's worth noting some of the differences that do come along when comparing lesbian, gay and bisexual adults with heterosexual adults. So as it says in the key finding on here, there was a higher proportion of LGB patients who were more likely to have a limiting long-standing illness. LGB adults were at high risk of alcohol-related harm, with about a third drinking over 14 units a week compared to a quarter of heterosexual adults. Again, from a smoking background point of view, more LGBT adults than heterosexual adults were smokers, and the LGBT adults had lower average mental well-being scores, and 16% of the LGBT adults said they had a mental, behavioural or neurodevelopmental disorder as a long-standing condition, compared with 6% of heterosexual adults. So there's that bit about our sort of public health work there to have a think about. Interestingly, from my perspective, and I'm purely speaking as an individual now, as somebody that is diagnosed as autistic with an Asperger's type of autism, you do see a small correlation amongst people sort of identifying as LGBT plus and those with neurodevelopmental conditions as well. If we think about the health inequalities that the LGBT plus population face, we know that the LGBT plus community has much lower levels of engagement with healthcare services. The figures stated that they were less likely to visit their GP and more likely to use emergency or minor injury service. And I think that was thought to be due to both actual and feared discrimination experienced by LGBT plus people across health services. And that was for a number of reasons. It included failing to acknowledge or involve a same-sex partner in the decision-making around their health, and also making heteronormative assumptions about them. If somebody sees me with a wedding ring on and they say, "Oh, what does your wife do?" And then I explain that I have a husband instead, that question could be, "What does your spouse do?" And then I have, the option to tell them that I've got a husband. I think as well, obviously in primary care, you've got a relatively small number of clinicians, and I do wonder as well whether perhaps if LGBT plus patients have had a particularly negative experience with one GP in a practice, that's more likely to affect how they engage with a practice in the future. Stonewall and YouGov did some work looking at the experiences of LGBT plus people accessing healthcare. Again, quite worrying findings, really. About a quarter witnessed discriminatory or negative remarks about other LGBT people amongst healthcare staff in the last 12 months. About a quarter had said they'd experienced inappropriate curiosity from healthcare staff regarding their sexuality or gender identity. 10% said they'd been outed without consent by healthcare staff in front of other staff or patients. 14% had avoided treatment for fear of discrimination. 21% of surgeries had been found to display an equal opportunities statement relating to sexual orientation. But obviously that means that 79% of surgeries hadn't. And less than 10% of patients said that they felt their surgery was a welcoming environment for them. What we do know, and again, I go back to the current sort of political climate, is we know that transgender patients, they seem to experience the highest rates of prejudice, health and social inequalities. To any of you that have referred patients into gender identity clinics, you'll be aware that waiting times are horrendously long, and at the moment, waiting times from referral to first appointment can be up to 3 years. And we know that over 2/3 of patients state that they've experienced depression in the last year, with a significant number considering or attempting suicide. So there's a massive kind of mental health burden and workload around these patients as well. We also know that trans patients are subject to much higher rates of verbal and violent hate crimes, as well as discrimination in the workplace. And I was looking at some figures the other day, and I think it said that 2021 and 2022 had the highest number of recorded hate crimes against trans people on record. I'm sure that does represent incidents, but it may well also represent a greater comfort in coming forward, in order that kind of they can have their claims sort of dealt with. I think it's worthwhile sort of having a think about the social and safety issues for LGBT plus people. We know that 1/3 of LGBT plus people have been threatened with being outed. So kind of having their sexual orientation or their gender identity revealed to other people in a way that feels uncomfortable with them, for them, and without their consent. One of the things that we know is that for the LGBT plus population, social isolation can be very extreme, especially in rural areas. Obviously, kind of, as I'm sure kind of you've come across in other work in the EDI sort of stream, we know that communities naturally tend to flock together for support amongst one another. And if you are a member of the LGBT plus community in a very isolated rural area, and obviously kind of in Derbyshire, kind of we've got a lot of isolated rural areas, that can be an issue. I suppose it's also one of the plus points of social media, the fact that, kind of it is a lot easier to connect people who are looking for like-minded individuals across geographical divides. As I mentioned earlier, we know homophobic and transphobic hate crimes are on the rise, and they doubled between 2014 and 2018. And one of the things that perhaps isn't as well recognised is how high the rates of domestic violence are in LGBT plus people. And in those communities, it often goes unreported. If we think about, domestic violence, kind of our mind naturally takes us often to a male attacking a female. Whereas it was interesting to note that 50% of men who identify as LGBT plus state they have experienced at least one incident of domestic violence from either a partner or a family member since age 16. So that may well be, kind of a gay man, being physically assaulted by a family member, father, brother, uncle, etc., as a result of their sexuality. And as I've noted on here, that business of familial rejection and family abuse and violence account for LGBT plus people being overrepresented amongst the homeless population as well. So that's, again, something to kind of think about, kind of if you're coming across in your day-to-day practice any kind of homeless patients, it might be relevant to explore, kind of sexuality with them? Is that one of the things that's led to their homelessness, and something that perhaps support can be offered around? Again, as I'm sure you've sort of seen in other areas of EDI work, we recognise this concept of intersectionality, whereby if patients belong to more than one group, sometimes increased stigma can occur based on the multiple characteristics that they have. So if we think about kind of age initially, we know that amongst children, more than 60% experience verbal abuse, and they can struggle with familial rejection due to coming out either in relation to their sexual orientation or their gender identity. And that in itself, as I say, feeds into mental health issues, homelessness, as I've already mentioned. Older people, again, we kind of think about the LGBT plus population, I think generally kind of in a sort of, this is something that's, you know, people under 40, forgetting that, you know, kind of there are elderly patients that identify as LGBT plus, who again can be at risk of increased social isolation, but also kind of on a practical level, they are often less likely to access informal care from family members. Now, that might be due to the fact that they don't have don't have children, or they're of an age whereby being LGBT plus was so outside the societal norms that they lost contact with their birth family at that time, and often increasingly, you know, kind of rely on friends as an informal family network. And as we all know, with our geriatric sort of population, you know, kind of as people get older, their friendship circles dwindle as friends pass away or perhaps are infirm and unable to help in ways that they once did. So certainly kind of older people from the LGBT plus is a community, I think, is an area that we perhaps sort of forget about and do well to kind of remember. People from the BAME communities, we know, experience greater levels of prejudice. It's estimated that 25% of LGBT plus people from BAME communities are not open about their sexuality to anyone else, and that 20% have avoided seeking medical care in relation to their LGBT plus identity. So this can include people who either don't present or have very late presentations of say kind of sexually transmitted illnesses and things like that in relation to some of their sexual practices, but they don't then seek help for fear of sort of stigma around doing so. We know that from a religious point of view, people that come from a strong religious background are more likely to experience family rejection, and can often be less likely to be sort of out due to conflicts of faith. You know, I again, sort of just speaking about my own experience here, you know, kind of I am a Christian. I was brought up in a strong Christian tradition, and I was always aware growing up that being gay was and remains an issue for the Christian church. And because it was an issue for the church, that made it equally an issue for me. And I was in my very late 20s before I came out and had relationships with anyone, because I spent a long time trying to tally in my own mind, you know, kind of how my sexuality and sexual attraction equally kind of was compatible with my faith. And some of you will be aware that even in the, you know, sort of Church of England, so the state church of the UK, they have just passed legislation to permit blessings of same-sex couples, but they will not conduct a same-sex marriage in a Church of England church as things stand currently, nor is it possible to be a ordained minister in the Church of England if you are married. You can if you are in a celibate civil partnership, but not if you are in a marriage. And finally, disability. We know there's greater difficulty accessing services, higher rates of self-harm, and that people who are disabled and from the LGBT plus communities are more likely to have those difficulties. So I really just wanted to spend the last sort of 10 minutes or so just sort of having a bit of a sort of general kind of chat really about what circumstances people have become aware that a patient that they've been dealing with comes from the LGBT plus community, and what usually prompts you to inquire about it. Because as I've mentioned earlier, you know, kind of it's not something whereby, you know, kind of patients come through the door wearing a badge saying that they're from these sort of communities, and it's often something that isn't known about until we inquire. But equally, as I've mentioned, it might be helpful to provide the best healthcare for patients to know about it. So I don't know if it's if anybody kind of has any sort of specific sort of experiences that they feel sort of able to kind of share, you know, kind of at present based on their own clinical practice, or where kind of they perhaps feel they've made a really good job of doing something, or perhaps where they feel that they put their foot in it and wish they could have done something differently. I just thought it was interesting to kind of hear any experiences that people had come across to date at this point in time. Oh, Gail.
Hi, James. Good to see you. As you'll probably realise, I'm at some crustacean, so just
Bless you.
mute me if you can't hear me.
No, we can hear you perfectly.
Oh, great. I suppose back in the early days of my partnership, it became most apparent when I had lesbian couples come in who were wanting to conceive and have a baby, and that brought all sorts of issues for them, because you know, back in the day it was like find a male friend and a syringe. It was so awful for them. And then having care, like you say, you know, two people of the same gender turning up to appointments, it's all sorts of queries and looks from the people they encountered, and then bringing up children, I think, in that environment again raises all sorts of questions. And I think it's more recently when I looked after a couple that a female couple that realised things were easier in the sense that they've got good antenatal care, their needs and sensitivities were taken into account. But then when the babies were small, they had twins. Again, it's those looks, and you know, we work really hard, I think, as a practice to discuss as a whole practice team our attitudes and our relationships with patients of whatever gender, orientation, etc., etc. So I think there's a lot to think about as a team, isn't there? I've got to mute again now.
Yeah, and I think that raises a really good point, because I mean, I know I've come across patients before, particularly you know, kind of a female same-sex couples that have brought babies in, even for things like baby immunizations, and the opening gambit from the nurse is who's mum, and you know, often both are, and you know, kind of it's those sorts of little things like that you sort of mentioned that are really kind of you know, I think make a huge difference for the patient as well, but it's easy to slip, you know, kind of if you're not kind of thinking about that. So yeah, that's a really nice example. Certainly for myself as a patient, I've often found that, again, it's around sort of that explanation of, you know, kind of who the person is that's coming with you. Sometimes, you know, kind of even like kind of forms and things can be a bit sort of antiquated, you know, kind of, are you married? Yes. What is your wife's name? Well, then you're kind of like trying to amend things. but yeah, kind of interesting that kind of you raise that around sort of the fertility side of things, which, you know, kind of I will include, you know, a bit more detail about in the next session. Anybody else with any sort of examples of when they've had consultations with LGBT plus patients that either a patient's sort of sexuality or gender identity was, you know, kind of an intrinsic part of that consultation, or something that ended up being a surprise, or you felt that kind of the consultation didn't go well? Zora.
Yeah, hi James. Thanks, that's really interesting. Yeah, I suppose it's kind of what you say about, if a patient comes in, the default is sort of assuming, if a patient doesn't state it to you and they refer to their partner, it's that kind of not knowing that I sometimes find difficult, you know, to sort of ascertain if their partner is the same sex or, you know, opposite sex. It's quite difficult. And so I've had consultations when that it's a woman who's come in with her female partner, or they've been married, and I think that's easier, and they've been quite quick to introduce them, and I think that means that we're, you know, you're kind of on the same page, you know, and you don't sort of have to query it. Because I think it's sometimes when you don't know, and I had a consultation recently, and I'd seen it from the previous consultation records, so I knew that the man, it was a telephone call actually, so I knew that his partner was a man. So that's kind of, I think it's that sort of grey area, like you say, if somebody comes in and you can see that a patient's sort of ethnic background or whatever, whereas that it is that kind of difficulty, and I find it sometimes quite difficult when to broach and how to ask, sort of being sensitive but not feeling awkward, you know, that kind of thing, I think.
And I think that's something that kind of, you know, kind of I'll go on to in a little bit more detail in the other sessions, but yeah, I've certainly found for myself that, you know, kind of the only way that I can generally do it is have the default setting of, and is that a male partner or a female partner? This is something I ask everyone because I've got it wrong in the past, is generally kind of, you know, kind of the patter, something along those lines that, you know, kind of I would use, because there's a risk, and I'm as guilty as this as anybody, whereby, you know, kind of if I've got a man coming in with a, I mean, it sounds awful, but, you know, kind of this is the way, you know, they say, don't they, the reason that we have stereotypes is because they're shortcuts to us as humans being able to make quick decisions about the world. You know, if I've got a man coming in who seems to have a high speaking voice and tells me he's a hairdresser, I might be more I might be more kind of stereotypically and wrongly inclined to ask about the gender of a partner than if I get a chap coming in that's full of plaster dust and, you know, kind of looks like he's just come off a building site. And that's completely wrong that I should do that, but I imagine there's probably, you know, kind of, I'm not the only person in the world that has tried to kind of make those sorts of snap sort of decisions as to whether, you know, kind of when you've got a limited amount of time for consultation, at face value, it's most likely this is going to be a heterosexual patient rather than somebody from, you know, kind of a differing sexuality. So I think kind of we can all fall into those pitfalls.
Mm.
So just close the chat down. I mean, just to kind of sum things up really then, so we've spoken today about how the LGBT plus community comprises a very diverse group of patients of differing biological sex, sexualities and gender identities. Historically, I think it's fair to say that those groups of patients have been marginalized by society, and despite, you know, kind of significant steps forward, those inequalities do still persist for the community, including, you know, kind of their access to healthcare and how supportive they feel the healthcare environments are around them. As I've mentioned, there are some specific health needs and behaviours within that community that may influence their risk of of harm and ill health. And as I say, kind of we'll touch on that far more in the next session, which is around the clinical side of things. And as I mentioned, intersectionality can result in worse outcomes for LGBT plus people. So as I say, kind of that brings sort of today's initial kind of primer and introduction to the subject to an end. The next talk that I'm planning on doing is on the 25th of May, same time, same place, and that will look at the clinical care of LGBT plus individuals. And as I say, kind of we'll look at issues around screening, gender dysphoria, and other clinical questions at that time. I will get the PDF of all of these slides sent on the distribution list of the attendees today via the GPTF office. And if there's any questions that people want to ask me in the meantime, that's my email address. And I'm more than happy to pick things up on email with people at a later date. But thank you for your time this afternoon. Hope you enjoyed your lunch if you were eating a sandwich at the same time. And for those of you that are in clinic, hope you have a good afternoon surgery and leave vaguely on time.